Female who was postoperative day 5 from a knee arthroscopy presented to the emergency department 3 days ago for shortness of breath. She was found to have a pulmonary embolism and subsequently coded in the ED, at which time a central line was placed. She is now hospital day 2 in the ICU and becomes neutropenic and febrile. How would you work up this patient?
I would start by obtaining sputum, urine, and blood cultures, one peripherally and the other from the central line. Then I would check a chest X-ray and start broad-spectrum antibiotics. If she is hemodynamically unstable, I would check frequent lactates.
Why do you need 2 blood cultures? Isn't the central line culture sufficient?
2 sources of blood culture would increase the positive predictive value in the case of both cultures being positive. Also, if the central line culture growth is quicker than the peripheral culture, the central line is likely the source of infection. Central line culture alone is not sufficient because it could be due to colonization.
Which antibiotics would you start?
As the patient is neutropenic and the infection is presumably healthcare associated, I would start vancomycin to cover methicillin-resistant Staph aureus and Zosyn for gram-negative and pseudomonal coverage, and an antifungal such as micafungin.
If all cultures were negative after 2 days and you'd already removed the central line, how long would you continue antibiotics?
If she remains hemodynamically unstable, I would continue antibiotics for at least 7 days. Negative blood cultures don't rule out bacterial infection. The risk of discontinuing antibiotics in an unstable patient far outweighs the risk of continuing.
Aren't you concerned about C. diff infection?
C. diff is a concern with ongoing broad-spectrum antibiotics. In unstable patients, however, the risk of C. difficile is outweighed by the risk of worsening shock in the setting of a possible bacterial infection.
What is your goal blood pressure in septic shock?
That would depend on the patient's pre-hospitalization baseline blood pressure. In baseline normotensive patients, I would maintain a MAP of 60 to 65, changing my target based on signs of adequate organ perfusion.
You gave 2 liters of lactated ringers during the first hour, and the MAP remains below 60. What would you do next?
I would start the patient on a norepinephrine infusion.
Why not phenylephrine or epinephrine?
Norepinephrine or dopamine are the recommended first-choice vasopressors in septic shock. Given that this patient is not tachycardic and has no arrhythmia so far, neosynephrine might not be beneficial. The epinephrine should be avoided as a first-line therapy.
The patient is still hypotensive and the heart rate is 85 beats per minute. What would you add next?
Either vasopressin or epinephrine could be used at this point. I would choose epinephrine if I believed there was a component of cardiogenic shock. Otherwise, I would add vasopressin.
What invasive monitors would you use?
I would place an arterial line. The blood pressure estimation with cuff is commonly inaccurate in shock. An arterial line provides a more reproducible measurement as well as analysis of waveform for pulse pressure variation to help manage the fluid resuscitation dynamically.
Would you use a PA catheter?
I would not use a PA catheter. I don't believe it will give me any relevant information that I could not obtain from a transthoracic echo or a transesophageal echo, so the risks of inserting one will likely outweigh any benefits.
The following abnormal labs results are back. Glucose 160, PT 2 times normal, PTT 2 times normal, creatinine 2.5, and hematocrit 25. Would you transfuse?
No, I would not transfuse either packed red blood cells or FFP at this time if the patient is not actively bleeding.
What about the high blood sugar? Would you start insulin IV? What is your goal blood sugar?
I would not start IV insulin unless the glucose is greater than 180. My goal would be a glucose between 140 and 180 to avoid an episode of hypoglycemia.
1 day later, the patient is off pressors. She is now oliguric. A bedside transthoracic echocardiogram shows a depressed left ventricle with low cardiac output. Would you use dopamine to correct the oliguria?
No, Dopamine has no renal protective effect, and it would not be my first-line inotropic agent in this case. If the oliguria appears to be secondary to CHF, I would start dobutamine.